So we are here tonight on season 6, episode 8. And that's hard for me to believe that we've gotten that far, but thank you all for being with us. Dr. Tennant, I know you and Pat and Dr. Mark, you all have such great things ahead of us. So I'm going to stop talking and let you take over. It's all yours, Doc. Thanks so much.
Hey, thank you very much, Jamie. Again, it's great to be here, and we've got a good show planned for you. I've got my usual education message, but I'm going to be followed by Pat Irwin and my good associate, Dr. Ibsen, who's going to be talking about our opioid access program, particularly as it relates with medical boards. So we're going to have a pretty good program here tonight. As far as the educational program goes tonight, I'm here to talk tonight about something that, in a way, may scare you when I say the word. It may offend you when I say the word. You may discard it when I say the word, but the word is hormones. And I'm here to tell you that if you have adhesive arachnoiditis or another severe painful condition, you're going to have to rethink the term hormones, what it means, because I want to say it right out front. You can't get much recovery and much regeneration without the use of certain hormones. So there's a set of hormones that we're going to talk about tonight. But let me just talk in terms again about what is a hormone. Technically, a hormone is a chemical in the body that's made in some organ in the body, and it enters the bloodstream and travels in the bloodstream to some other tissues, and then it has some kind of a biologic action. Now, you're familiar with some of those places that make the hormones, like the testicle, the ovary, the adrenal gland, the thymus gland, the thyroid. So everybody's familiar with where the hormones are made. And unfortunately, when you use the word hormone, people think of the sex hormones, and they think in terms of sexual relations, menopause, menstrual cycles, and they get off into that realm. And that's just one little aspect of what hormones do in the body. And there are some hormones we're going to talk about tonight that you may never have heard of. But at any rate, the first thing that you need to know is the hormones we're going to talk about tonight have 3 basic functions that are critical for an intractable pain patient. Number 1, they regenerate tissue. There are certain hormones, and you cannot get your pain reduced or even under control, much less reduce it permanently, unless you regenerate certain tissues, nerve tissues. And you can only do that if you've got hormones in the body, either your own or some you take, to make that nerve regenerate. So remember, if you want to get better, you're mortgaged to hormones, because those hormones are going to be essential to regenerate your nerves that have been damaged or injured by anything from inflammation to an epidural to an injury. So that's one function. It regenerates tissues and nerves. Now, the second thing it does is that a lot of the hormones have an immune function, meaning they suppress things like inflammation and even viruses. And so some of the hormones have a specific effect on lymphocytes, on interleukins, and even on viruses themselves. And particularly, we know that the Epstein-Barr reactivation is a serious disease itself, and that we're having to deal with Epstein-Barr reactivation almost routinely now when it comes to dealing with intractable pain or adhesive arachnoiditis. Now, there's a third thing that hormones do that's totally unknown. And I guarantee you, if you ask your doctors, they won't have a clue. Nobody knows about the third thing that hormones do. But some hormones act as partners with your natural neurotransmitters in the brain to relieve pain, okay? In other words, you may not realize this, but your endorphin receptors and your dopamine receptors, your serotonin receptors, do not function well unless it has a partner. That partner, the big one is testosterone, but also it partners with cortisone. And so if you don't have enough cortisone and enough testosterone, do you know you're not going to get good pain relief? Because endorphin and opioids only function in partnership with these hormones. That's why they've got to be at a certain blood level for you to get pain relief. Okay, in other words, let me put it another way. If you've got low testosterone, you can go ahead and take all the opioids you want. You can even have an intrathecal opioid pump. You can take a fentanyl. You can take Dilaudid. It's not going to work because that you've got to have enough testosterone in your bloodstream to make the receptor work and give you pain relief. Now, this is a big secret that no one seems to know, but it's well documented in the scientific literature, well known to those who have been in this field. But it's like a lot of things these days, the ignorance out there overwhelms you. Okay? Now, we're going to start talking about some specific hormones, and we're going to, in some ways, start at the beginning. And that we're going to first off talk about the hormone colostrum. Okay? Now, why at the beginning? Well, when you were born, your mother is going to secrete colostrum for a few hours after you've come out of the womb. Now, why does the mother have a lot of colostrum in her breast milk at that time? She has it there because colostrum is filled with growth hormones, and it's number one. And secondly, it's filled with a lot of autoimmune activity because you get all that colostrum right after you're born, and the first day you're born, the good Lord knew what he was doing. He made sure that this colostrum, number one, was going to make you grow, but at the same time, make sure you weren't going to get infected. And so that's colostrum. Now, what's amazing is that some really bright entrepreneurial scientists figured out that they could harvest colostrum from certain animals and put it on the commercial market. And guess what? If you know how to take it and you know what dosage to take, it works just like in the adult, like it did when you were a 12-hour-old infant. And that is, it'll regrow your nerves and it'll protect you from infections. Okay? So why wouldn't you want to take this? Well, you would. Okay? Now, I first got turned on to the benefits of colostrum by people with EDS, Ehlers-Danlos syndrome. And they were the ones that told me that they functioned very well with colostrum. And now I understand why people with Ehlers-Danlos syndrome and Marfan syndrome and what are called connective tissue diseases have a metabolic genetic defect in their collagen growth. So their tissues don't have normal collagen. Their nerves don't have normal collagen. Their cauda does not. Their glial cells do not. Their arachnoid does not. Their sciatic nerve does not have adequate collagen, or it might say effectively developed collagen. Call it what you want, the collagen isn't normal. However, if you take colostrum, it's got a lot of growth hormones in it that kind of make up for some of your genetic deficiencies. And so I was not, in retrospect, I'm not at all surprised that it was EDS people who brought colostrum to my attention. And I frankly recommend that everybody with EDS take colostrum, and including, if you want to, from a preventive point of view, I almost think that every child who has EDS or teenager, maybe they ought to start on low doses of colostrum as a preventive. Now, I'm going to read you a list of something that you can go ahead and forget. But what I want you to know is that there are a lot of unknown hormones, or what we call growth factors, that are in colostrum. And I'm just going to read you a list of them. You can forget it, but what I want you to know is it loaded with everything you need to grow tissue. That's got insulin growth factor, fibroblast growth factor, platelet growth factor, epithelial growth factor, and transforming growth factor. Now, all those factors, what does it do? What does it add up to? Heals your wounds, grows your tissue, reduces your pain. In other words, It really does work. Now, besides all these growth factors, colostrum also has a great number of compounds that suppress interleukins and actually fight viruses. Okay, so you want to take them. Now, one of the problems that I can see we've had with colostrum, we've been recommending a dose that's too low. Okay, now that's been the problem with a lot of our natural supplements. We start off and we don't know what the dosage should be. So over time, it's finally figured out. Well, to get a real effect out of colostrum, you need to take 1,000 to 2,000 milligrams twice a day. Okay, you can look at some of my own writings and see where I was recommending only maybe 800 or 900 a day, but you really want to be taking twice that much. Who should be taking it? As far as I can see, anybody who's got severe intractable pain, central pain, adhesive arachnoiditis, any of the severe problems we deal with, you can't go wrong with colostrum, okay? And so I highly recommend it. Now, the second hormone I want to talk about is one called thymosin. Now, a lot of people don't think of thymosin. They know that it has something to do with the thymus gland, and that is correct. Thymosin is a hormone that is made in the thymus gland, okay? And it enters the bloodstream. And what's interesting about it, it's made out of amino acids, so it's also a peptide. So it is a peptide hormone. And so what does it do? It does a lot of the same things that colostrum does, except it's a little more specific. Its peptide effect really seems to be quite works very well on nerve tissue. And so, with arachnoiditis, it seems to be one of the peptides that has a great effect on the cauda equina and on the arachnoid membrane. But the other thing about thymosin is it comes from the thymus, and it's got some powerful anti-inflammatory and antiviral compounds in it. And so thymosin, you get a real twofer here. You get a real potent antiviral, anti-inflammatory effect, plus you get growth of nerves, including the arachnoid membrane and the cauda equina nerve roots. So again, thymosin is quite excellent. Incidentally, thymus is combined with another peptide called body protection compound, BPC 157. And that compound put together with BPC 157 is dynamite. You can't go wrong with it. It's an excellent regenerator of tissue. Now, the third hormone that I want to talk about, you may have heard of, but not know a whole lot about it. And that's the big long name called dehydroepiandrosterone, abbreviated DHEA. And so you're going to see DHEA written a lot. Now, DHEA is made actually in the spinal cord, okay? The spinal cord will actually make DHEA. Now, after it's made, what's interesting about DHEA, it converts part of its molecule to testosterone, androstenedione, progesterone, estrogen, and some of it is what's called DHEAS, which you don't really need to know. But what I want you to know is that DHEA is a hormone made in the spinal cord. Its specific purpose, its major purpose, is to heal nerve tissue. Now, there are plenty of studies about how DHEA makes injured spinal cords heal, and it certainly will make the cauda equina nerve roots and the arachnoid heal. It's a very great regenerative compound, and I highly recommend it. Now, it also works on the glial cells on central pain. So DHEA, again, is a winner. We've recommended dosages that have been too low in the past. To make this hormone really effective, you need 200 milligrams in the morning and 200 at bedtime. But again, it works out very well. Now, the next hormone I want to talk about is testosterone. Now, testosterone, the first thing I want you to understand is testosterone is in both males and females. Incidentally, estrogen is in males as well as females. It's the ratio that's different. Okay. In other words, males have about 4 times more testosterone than do females, but the purpose looks like the same in both. Now, testosterone is essential for pain relief. Okay. Now, which leads me in to the next thing I want to talk about. If you happen to be an intractable pain patient, you've got adhesive arachnoiditis, multiple sclerosis, CRPS, and you're deteriorating, you're not doing well, you need a hormone panel blood test. Now, today, your doctor can order from any laboratory, Quest, all of them, LabCorp, your local hospital, and you can go there and get a single blood tube that will test for testosterone, estrogen, progesterone, pregnenolone, and DHEA. And you need to have that done if you are not doing well. In other words, so many people are doing poorly, getting poor pain relief, they're deteriorating, and no one's bothered to tell them to get a hormone blood test. Because if you have a low level of DHEA or pregnenolone and particularly testosterone, you're going to have to take a replacement. That includes the women as well as the men. Remember, testosterone works on the endorphin receptors in the brain, and if you don't have adequate levels in your blood, you're just simply not going to get good pain relief. It's as simple as that. Now, doctors know all about medicating men with testosterone deficiency. There are pills, there are shots, there are patches, any number of formulations. Now, with females, you can use those same formulations, but about 1/4 the dose. And that's how it works. So we do have lots of women pain patients who need to take testosterone. Now, I want to close out here today by giving you a case history and some, as the name of our project expounds, hope. Okay. And that is, in my opinion, the wave of the future for getting cure or near cure is the combination of peptides and hormones. Okay. I'm not sure which combination should be used or which one is the best, but I will tell you this. I reviewed a case this week of a gentleman who's got a terrible case of adhesive arachnoiditis. He actually fell in a hang gliding accident, fractured spine, etc. Lived, but ended up with adhesive arachnoiditis. Today, he takes no opioids. But what does he take? All 4 of the hormones I've talked about today, colostrum, DHEA, thymosin, and testosterone, and he also takes about 4 peptides. He's probably the poster child for the future. In other words, what I want you to know, the combination of these new peptides that enter the metabolic pathways to regenerate tissue, and then you've got the hormones as generators, that's where we're getting some payoff. And I see cases each week that are taking 1 or 2 peptides, maybe 1 or 2 hormones, and they seem to be doing pretty well. So that's kind of the wave of the future. So again, I want to summarize and close with this one statement, however. If you are deteriorating, your pain is getting worse, and you're not doing well, you need a hormone panel, and you need to think in terms or consider starting some of these other hormones. With that, the educational message is over for the day. We're going to shift on to something else. And that's Pat Irwin is going to come on and with our Access Opioid Project and give us her report on where they stand with her efforts with medical board and some other activities. Again, the goal here with what she's working on, keep opioids accessible to people who need them. So Pat, where are you?
No, right here, Dr. Tennant. Thank you so
All right.
much for the introduction. I'm very happy to be here tonight. We have a full agenda for the advocacy session. I'm going to be first giving a few just general updates. Then I will give an update on what is happening in Washington State, and a lot is going on there. Then Monty Goddard will be coming on to give some information about a pain conference that's going to be happening. And last but not least, Dr. Ibsen is here to give us updates on his fight with the medical boards and other lovely regulatory bodies. So with that, let me first say that we have made it to our 7th advocacy session, which is really wonderful. A lot of good work from everybody. If you're not a formal part of the initiative yet and you want to formally be on that list and get emails, more emails, everybody loves emails, go ahead and direct message me on Doc Talks or Facebook, and I will get you on that list so that you can be officially on there. So some general updates. First is some good news. Dr. Haddadin, who presented at our last advocacy session, it was right before he got his final hearing from the California Medical Board. His case was cleared. It was dropped, no penalties. And so he and all of us, yes, we're thrilled. I'm not sure all of you heard this. So excellent, excellent news for Dr. Haddadin. So yay, another victory. The fight is not over. I think they bowed to the pressure, this one time, but we're not letting up the pressure because it's just going to keep happening if we don't keep right on top of them. But good news. The second thing is for a legislative update, which we don't normally talk about what's going on with the legislator, but I thought this was important. One of our advocates got a hearing with a California legislative aide and a U.S. congressman's aide, health aide. And it's going to be sometime the end of this month or the beginning of December. And so she asked if I could put together a packet of material for her to give. Yes, and yes, Dr. Ibsen, we will make sure you get the date. And so I'll post that on the Doc Talks Facebook page so you can see what material I've got for her and anyone else who wants to send me material for her to present. She has 45 minutes, which is just unheard of. So we're really, really pleased with that. We'll keep you posted. The other just general update, I'm sure most of you've seen it, but Red has posted, thank you, Jamie, a wonderful new PowerPoint video live with him going live on how the entire system, of course, as we well know, is corrupt and what the statistics are and how we can go about fighting it. So if you haven't seen Red's latest video, please go to Doc Talks and look at it there. And Jamie, thank you so much for that. That was a lot of work and it really came out great. Really, really great presentation. And David is saying, okay, he's got a report going. I'll catch you at the end here, David. That's really good. Let's switch now to what's going on with Washington State because, oh my goodness, so much is going on. I think our main advocate, her name is Maria Higginbotham, and she has been in the fight for over 4 years with the Washington State Medical Board, looking at the rules. Oh, okay, 6 years.
15.
15. Yes. Looking at the rules, her big win was she got the Washington Medical Commission, which is the name for their board, to agree to review the rules. I think you heard that last time at our last meeting. And the good news is they are going through section by section, looking at each piece. They're much more detailed than our experience in California, but they are definitely letting patients have input. Unfortunately, they're also letting some anti-opioid people have input. So she called me and said, Pat, I'd like a second set of ears. Could you listen in? They're having a physician named Dr. Scheischer come and present. It's called, you're going to love this, Better Prescribing. Does that freak you out right there on the side? Better prescribing, what does it have to do with? Giving doctors reports on how well they're doing. Do they only give 7 days of opioids with their post-op patients. If they get more than 7 days, they get a naughty notch. Yes, exactly. Now, he says, of course, in fairness, they're not naughty notches, they're teaching opportunities. But you know, and I know what has happened in the state of Washington when these docs get the reports. They drop their patients. Surprise, right? Surprise. Oh my goodness. We don't have direct statistics on that, but we know firsthand that it's happening. So when I heard this, I said, absolutely, Maria, I will join in. And Monty, being the good-hearted soul that he is, joined me. And we listened to the workshop in which this physician gave his presentation on better prescribing. It is, in fact, only right now for acute pain, but as he was talking, you could hear the anti-opioid sentiment come through. He's also an attorney, so you know he couched his words very carefully, but just listening to him, I mean, my hair was standing up and I was, oh my goodness. Maria was not overly cautious to think that there was something going on here. The good news was that Monty and I were both able to give verbal comments right then and there to him. And we said, we have concerns with, let me read you what he said, and you can see why we had concerns. He said directly about, Monty gave the story about his wife and her chronic pain. Yes, and how the opioids helped her. And he said to Monty, oh, well, this was a prior generation and a prior definition of good medicine. This is to Monty about his wife, which does not meet today's definition of the standard and is not appropriate, quote unquote. So I got in there and said, excuse me, but do you have evidence to show, where is this new evidence to show that this was prior guidelines? What's new guidelines? Where are the new guidelines? Nothing in the CDC, not even anything in the CDC guidelines that you can't give opioids and what the dose limits are. So what are you talking about? Yes, money, this hidden, he kept talking about new recommendations. And thank heavens, and then Monty spoke up and said, and agreed with me, you need patients involved in your process of this to be a part of whatever you're doing so we can give feedback. If it involves us, then we should be there. And thank heavens, there was another physician on the panel who wasn't a part of the medical commission, and he spoke up because I thought I was going crazy, and he said, I'm worried about this quote of prior definition. He called him on it. He said, what are you talking about prior definition? What do you mean prior definition? There is no prior definition. We are under the same guidelines that we always had. And then he said point blank, this was just music to my ears, there is nothing in the CDC guidelines that prohibits opioid prescription, and there is no dose limit. Thank you, Dr. Stanos. So at that point, we knew, thank heavens, we weren't going crazy. And there was a physician in the group that, bless his heart, spoke up. So on that note, we did not let just our verbal comments go. I talked with Red, and Red agreed we should send this gentleman something in writing, which we did. Huge packet of stuff went out today, all of Red's circles and charts and arrows and all of that, along with a nice letter signed by me saying, we're watching you. We are watching you. We want a patient in your group. We want to see the data, because guess where he's going next? Frightening. Co-prescribing. Reports weren't enough. This is the medical commission. This is right? This is like our California Medical Association. This is
What do you mean co-prescribing?
opioids and benzodiazepines.
Got it.
Going after that with reports, and you can imagine what's going to happen, doctors. And when those doctors get that report,
Based on what?
yeah, they're going to stop prescribing or cut prescribing, and he keeps saying, oh, it's only about new patients. It's only about new patients. Does it matter, Dr. Ibsen? No.
It
He's like
matters.
a he's
It
like a
matters
law-
to everybody who's on both.
The
he,
fear, the
he's like a
fear is the
lawyer.
fear,
He's
right?
like a
The
lawyer.
fear, they're peddling fear. And
He-
fear is what drives this entire system. Fear from the DEA, fear from the attorney generals. And now, right or wrong, I mean, give the gentleman the benefit of the doubt
No.
and say it's unintended. No, Marxist, no. Unintended, it's fear, regardless. And they're peddling in fear, which is exactly what we don't need. So I will
Baffling
keep
is
you
BS.
posted as to whether I get a response from this gentleman. But we are not letting it go. I intend to at least listen in to the rules meeting. I'm going to follow the website where he posts his progress on these data reports. And I'll let you know what we find out. What it did point out to me for others who are doing their boards is pay attention to what your medical association thinks about opiates. Didn't dawn on me. So in this case, the board in Washington State seems fairly open to wanting to do the right thing for pain patients, but it's the medical commission that doesn't. So we're just kind of to the wise out there when you're looking at your group, look at both the medical association as well as your board. And I think on that, I am going to hand it over to Monty. Are you there? Can we unmute Monty? Monty has some really good news for us tonight. I hope he's here.
Welcome, Monty.
Here, Pat.
Oh, great.
Okay. I got my text so I can get it all in.
Good. Welcome.
And good evening, Dr. Tennant, Jamie, and all joining in today's Doc Talks. Thank you for this opportunity to share what I consider good news. This coming December 17th, there will be a one-day forum, which coincidentally will be held at Pat's alma mater, the California State University, Sacramento. This forum has been in the planning stages for several months. Is titled Patients and Prescriptions, Addressing Challenges, Finding Opportunities. The forum is hosted by the California Department of Consumer Affairs and California's Medical Board, Board of Pharmacy, Board of Registered Nursing, Physician Assistant Board, Osteopathic Medical Board, and Dental Board. In my opinion, this forum is the result of a chain of events that began in February 2022 with a public comment delivered by Kristen Ogden at an interested parties workshop of the Medical Board of California. I believe Kristen's comment and two physician board members' surprising comments in reply, along with subsequent board discussions, became the genesis of the Medical Board of California's process of updating their opioid prescribing guidelines. I and several other advocates and patients participated in that endeavor, which ultimately resulted in the publishing of the Medical Board's much improved 2023 guidelines. The publishing of these guidelines' unfortunate failure to achieve their intended goal of encouraging physicians to return to the care of patients in pain has been a focus of my and other comments to the Medical Board at their subsequent public meetings. Then, early last year, I met Pat Irwin, who was sounding the alarm about the supply chain shortages of the injunctive relief provisions of the state AG's nationwide settlement with the three major distributors of controlled substances caused. Incorporating the corollary harm to patients resulting from the reactionary policies implemented by insurance and healthcare providers, In response to this injunction-induced supply shortages, Pat, myself, and others have been speaking to this issue to both the medical board and the Board of Pharmacy meetings. We specifically asked both boards to work together with the Department of Consumer Affairs and other healthcare boards to address this very real patient harm. I believe we even motivated one medical board physician member, speaking for himself, not on behalf of the medical board, to make similar public comments at a Board of Pharmacy meeting in October of last year. Both Pat and I are teamed on the forum's agenda as in-person presenters. I will also be a panelist. Our presentation will be focused on 3 issues: the medical board's 2023 prescribing guidelines. They're much improved, but with too little adoption. The state AG's nationwide opioid settlement, specifically the settlement's injunction, and the insurance company's business practices, their reactionary policies, and prior approval requirements. In addition to the PowerPoint brief that I will present, Pat will share her story, and I will share my wife's and mine. The forum's agenda has not yet been released. I do know that for sure, but I do not know for sure, but I expect other presenters and panelists to be from the Department of Consumer Affairs, some, if not all, of the medical boards, the AG's office, the DEA, the distributors, the MOUD community, and potentially others. The forum is scheduled from 8 a.m. to 5 a.m. with a lunch break. The morning will consist of presentations, and the afternoon will be a Q&A and breakout sessions. In-person attendance maximum is 200, not counting Department of Consumer Affairs and board staff. The virtual attendance for this forum will be limited to 500. Last I heard, registration is tentatively planned to begin mid-November. I have cautious optimism for this December forum. I also hope by sharing with you today how we got here, beginning with Kristen's February 2022 public comment to the Medical Board of California, will convince others. Steady, consistent, firm, respectful advocating with these healthcare boards can bear fruit. Thank you for listening.
Thank you.
Monty, can I
much,
ask you a
Monty.
question?
Thank you so much. Finally, everyone, some good news. I think it would be hard to say this isn't good news. And obviously, I've seen the comments. We will let you know as soon as registration is open, because it's really limited to, what did you say, 200 live?
200 in person, not counting staff.
200 in person, so it's going to be really limited. So I want to make sure this group, I'm looking at you, Dr. Tennant and Dr. Ibsen, I want to make sure that we get to you as soon as it's open so that you could go there in person if you wanted. And then it will also be available online. So as soon as we get that, this group will be the first to know. We're very, very excited. And again, I want to reiterate what Monty said is, it's so easy to get discouraged, and especially with these medical boards that are so cruel in many of the things that they do. But Kristen hung in there, and Monty and others hung in there, just meeting after meeting after meeting. And it did that work of building that relationship, as gosh awful hard as it was, really made a difference. So please don't give up. Please hold some hope that you could do that too with your board. I want to offer that if you're working with your board like Maria was, and you want a second opinion or you need a little help, give me a call. Give us a call. It doesn't hurt for us to jump in, and unlike some organizations, we don't charge. So our consult is free. We're more than happy to help you with your board meetings. Do you have, I think we could open it for questions. First of all, to Monty about the conference, to me about what's going on in Washington, and then specifically, I saw him disappear, to Dr. Ibsen, if he has a chance to come back online. I didn't see him go.
My question is Monty, what is the DEA doing at this conference? I mean, that's law enforcement. They have absolutely no business dictating the practice of medicine to anyone. And in fact, within the laws of this country, it clearly points that out, that they have their role is strictly diversion and has nothing to do with the dose or the dosage amount and stuff. So Monty, I ask you again, I mean, I think you should question their presence anywhere within a meeting that deals with medicine and medical therapeutic medicinal protocols or treatment programs. And I just want to ask you a question on that one.
Well, I'm not positive that I understand why you're asking me that question. I'm not in charge of the forum, but I do know this. They're going to start. This agenda was outlined for me roughly, just off of a napkin, that they want to start the forum with some introductory comments from the boards and why they're there and all that kind of stuff. And then they want to go first with a primer on the regulatory requirements.
Yeah.
What are they? And the first couple presentations, the first two areas will be the regulatory requirements on pharmacists and the regulatory requirements on physicians. And those, I was told, would be submitted by presented by staff from the California Attorney General's office. And possibly with someone on staff with the DEA. That's what I know.
Yeah. And if I can jump in, I think my understanding from what Monty was saying is, in the first part, they want to get a lay of the land. What is the current situation that we're facing? It doesn't mean that they agree or don't agree. It's what is the world that we see and the challenges that we see for pain management. And then in the afternoon, they're going to have more small groups, Monty, tell me if I'm incorrect, where some of these problems that are identified early on can be worked on. So I think, we can't guarantee and tell you that this is going to be all wine and roses, because I don't think that it is. I think we're going to hear things that we don't want to hear. The point is that they valued patients' viewpoint enough to ask us to come and speak and give a fairly long PowerPoint presentation, relatively so. So is it going to be perfect? I think no, by any means. We're going to hear things we don't like. The presentations are probably going to raise our hackles, but it's to give an overall broad perspective. Monty, what do you think?
We're going to be in the room. That's huge, okay? My briefing, the one that we put together, that Pat and I put together, that I'm going to present in those PowerPoint slides, is openly critical of the medical board.
Yeah.
Okay. It uses a recent case. Pat mentioned it earlier in our meeting today. Well, I'm not going to name names, but some of the things the medical board has done post-publishing of their guidelines has absolutely been contributory to the fact that doctors dismiss them. That no, nothing's changed. We don't trust you. You're still doing dumb things like this. And one of them is the well-known case that Pat mentioned earlier. So I'm looking forward to it. And I'm tickled to death that the DEA is going to be in the room.
Can you get them to abandon the area of what we call morphine, the whole acronym of morphine milligram equivalent? You're gonna be discussing that
We
as
got
part of the issue?
Norm, have you ever read the California 2023 guidelines?
No, I have not.
You need to read it. They're only like 20. They're only like 20. They're only like 23 pages long.
Yes.
And they specifically do exclude MME except for one line that says uh, quoting California law, that when a doctor in California prescribes 90 MME or more, he has to quote unquote offer a prescription for naloxone. That was one of my contributions.
Yeah,
That wasn't the only one, but that was one of my contributions to the improvement of the guidelines.
To answer the question that was asked is why the DEA is there, because it doesn't matter what the medical boards say and what the guidelines say. If we don't get a buy-in from the DEA, and we can ask, what happened to a number of physicians, including our beloved Dr. Tennant, Dr. Weber, Dr. Bakoff, Dr. Anand. If the DEA doesn't have a buy-in, it doesn't matter what the state regulations are. The DEA comes in, suppresses the practice, and scares the pants off of everybody else who's doing pain management. So we've got to have their buy-in.
Exactly.
And that's why they've got to be there.
Thank you for that.
To answer the question about the DEA, it is the Public Health Emergency Declaration by the director of the Department of Health and Human Services that allows the agencies to set aside any law they want to perpetrate their public health initiative. So we know that federal interference with the practice of medicine is prohibited by law, but the Public Health Emergency Declaration overrides that, which is why I'm involved in suing the Department of Health and Human Services. They won't respond to my notice, but I'll have to file a district court lawsuit next year. So that's happening. Oh, and another on the side note, then I'll shut up. Today I made a lengthy report to the OIG at HHS about the entire nature of the entire opioid crisis hoax being fraudulent on its face, with none of the claims made by the prop group and all these anti-opioid people having any scientific basis whatsoever. So we'll see if that gets anywhere. I don't know, because the FBI hasn't been interested. So anyway, I'll shut up now.
No, David, thank you so much. And that's, I think, just for people who may not know, that's the Office of Inspector General, which is that key position at each of the big federal departments. And they are key players, and getting the information to them is really critical. So thank you, David.
This is really great, and I'm really excited. And I'm realizing that if we send a delegation to this meeting, it might be good for us to get together and rehearse so that we don't make things worse for ourselves by talking over people or clutching our pearls. I may wear pearls, I might not. But it's a question of how can we make a presentation that forwards our action and doesn't get us branded as gate crashers or revolutionaries or all the things that we truly are. So we have to hide our identity. It's a Trojan horse. But we may want to do a little rehearsal. And that's just a suggestion. Hopefully we can build on what's already accomplished, which is amazing stuff. Thank you. That's all I got.
Oh, Dr. Ibsen, that would be fantastic. As a matter of fact, once we know who's able to attend, I volunteer for creating a list if people are willing to share, and we can this is the group that's going in person. These are the people who will be listening online. I'll be willing to do that, so we can kind of, I think communicating is really, really going to help. And I don't know, well, I don't want Monty on the spot, but I'll have to ask him if he can share his slides ahead of time. I don't know if they'll allow that. I would hope so. It would be great, I think, for folks, especially those in person, to know what those slides are going to be. So you understand, just like you're saying, Dr. Ibsen, have a heads up for what to anticipate and how to respond. So I'll talk to Monty offline and see if that's acceptable or not, because I don't really know. We've got about 10 more minutes, and then I'll turn it back over to Dr. Tennant.
Sadly, that I don't know if it's related, that Dr. Anand had to turn himself in today. So I just wanted to report today. So that's one thing I wanted to point out. Talk to him about 40 minutes before he had to report in, and he wishes us all good luck. So yeah, I talked to his mom after he reported in today. So,
I'm so
I
sorry.
just wanted to let you know that.
Yeah, thank you for letting us know. Dr. Ibsen, before I turn it back to Dr. Tennant, do you have other updates on the advocacy front you would like to share? We got some time.
I got a minute or two. My federal case has gone quiet, which is just wonderful, although it's exasperating. I think it might be because of the federal shutdown. I don't know.
Oh,
But my attorney has reached out to the prosecutor and hasn't heard back.
yeah.
No news is awesome news. Um,
Yes.
the other update is, and I want to be at this meeting in December. The California Department of Investigation is sending my patients in California letters requesting that they agree to surrender or give permission for them to get their records. And it's kind of a threatening letter, and it threatens a subpoena if they don't agree, although the subpoena would be sent to me. So I have some anxious patients receiving naughtygrams with my name on them from the California Department of Investigation, and I don't like it. However, it's a fishing expedition. If their nets come up empty, then what I'm recommending my patients is that they don't surrender their constitutional rights to privacy, and that they wait for a subpoena, which is harder to get than asking people for their records. So you got to go to a judge to get a subpoena. So I don't know if that's going anywhere or not. I'll get over being offended, but I'll probably be able to talk to those people at this meeting in December. So it'll be a fun time. I think I've got an idea today, though, to have all my patients send the California Medical Board's guidelines to the California Department of Investigation, and so we'll be doing that.
Oh, very good. Good,
Thank
good,
you,
good.
Monty.
Can I tell you a little? Can I tell you a little story, Dr. Ibsen?
Sure.
Right after the guidelines got published, at the next medical, people don't understand the HQIU, which is the Health Quality Investigative Unit, which does the investigations in California for the medical board. That's the entity you're speaking of. They don't belong to the medical board. They belong to the Department of Consumer Affairs, which is over all of the boards, including my engineers board. But anyway, they had the lady that was running that at the time, that unit, do a report, quarterly report to the medical board. And at the end of that, in public comment, I asked her if the inspectors, her inspectors, had been educated and brought up to speed on the new guidelines, because the guidelines are a cultural change from what existed before. And her response was they were provided a copy.
They were.
Yep. And that was insufficient for me. So I beat him up on that.
Yeah. Thank you.
I used to work for the Department of Defense, and we worked with explosives. And when we wrote a piece of paper that people had to understand and implement, they had to get schooled on it. And they had to sign the damn thing that they had been schooled on before they were allowed to proceed. So that's what I would have liked to have seen.
Yeah. Well, I'll do it for you.
Perfect. Okay, thank you, Monty. With 5 minutes left, I'll turn it back to Dr. Tennant. Thank you, everyone, so much.
Pat, this is a very, not only informative, but very encouraging. I'm glad you're calling these people out. We're getting organized. We're not letting any party go up against us without counteroffensive. And let me just close out and remind you of something that is always on my mind. In this last 10 days, we've had the New England Journal of Medicine, the American Journal of the Medical Association, several other publications condemning, if you will, opioid treatment for one reason or another and under one terminology or another. But let me tell you the two things that I look for in all of the people, including the ones you've talked about. There's two characteristics I want to call to your attention. None of these people bring up the fact that untreated pain is a very serious biologic disease. It must be treated. It has all kinds of complications. They never talk about the risk of people who are untreated for pain. But the big one is, just like you're talking about all of these complaints, they want to see records, they want to condemn opioids. Where's their alternative? Okay. In other words, they're not offering any alternative. And I've had to sadly come to the conclusion they don't care whether you get any treatment. In other words, if somebody said we have concerns about dosages or formulations or this or that, and here's what we think is a good substitute, that would be different. But that's not the attitude. The attitude is stop your treatment. We have nothing to offer and we have no suggestions. Now that's just immoral. Okay. If you've got a gripe and you don't like something, what's your alternative? And may I suggest that whoever you talk to, you don't like this? Where's your alternative? You don't like Valium or benzodiazepines? What's your alternative? They're not doing this. If you'll listen to their gripes and what they're saying, they're just simply attacking the drug and the patients with no care or no concern and no alternative to help people who are sick. To me, that's the tragedy of all of this. It's like we just are going to cast out everybody and do nothing. So
And
again,
Dr. Tennant, to follow up with that,
yes.
I sent you an email about a doctor in Bensalem, Pennsylvania, the town that Dr. Anand is from, who was convicted of inappropriate prescribing of testosterone. So they're not stopping with opiates. So get used to people telling you that your thyroid dose is too high or this or that. So this is going to creep into medical freedom here real soon.
It's tragic. I mean, we are all humans and we are supposed to take care of our fellow humans. As far as I thought, that was basic humanity, but I see we're getting a different opinion out there. Anyway, thanks to all of you who are working so hard to help people and to defend our cause. With that, we'll sign off tonight. Again, I'm so grateful that we have you all. Good night.
Good night.
Thank you. Good night.
Thank you.
We're grateful for you too, Dr. Tennant. And
Thank
we're grateful for
you.
each and every one of
Good
you.
night, Valerie.
Thank you all so much. Good
Good
night,
night.
everyone.
Good night,
Night, everyone.
Jamie.
Good night,
Thank you.
Carson.
God bless you.
Good night,
God
John
Good
bless.
Boy.
night, Mark.
Good night. Love you,
Thank you all.
everybody.
Good
Keep you
night,
lifted.
Night,
everyone.
Dr.
You
Tennant.
Good
too.
night.
And don't
Good
forget,
night,
for those
John
of you
Boy.
that would like to, we'll still have our 15-minute after show off the record if you're interested.
Can I say a question for the 15 minutes? It won't take me 15 minutes.
Yes, of course. I will
God
after
save
we.
all the
Yep.
pain
So it's not.
warriors.
Okay.
Yep. Good night, everyone.